Hey everyone, Dr. Matt Geller here. Good to be back. Hope you all enjoyed that break. For my next guest, I have the best, our program chair, the best person possible that you can hear from on this next topic, Dr. Damon Dierker. Let's bring him in. What's going on, my friend?
Hey, Matt. How's the show?
It's exciting, to say the least. Just the energy has been coursing through this place. I'm surprised on a Saturday how many ODs want dry eye education. You know, I knew a lot, but I didn't know this many, so I'm thrilled. How about you?
I would say not surprised. I mean, look at the results from the survey. People want to have this information. It's the hottest topic, I think, in optometry right now, and it's the best way for us to be able to build our medical practices and take care of our patients and have great success. And looking forward to talking about how InflammaDry has been part of that process for me at Eye Surgeons.
Yeah, absolutely. So I think in order to really understand and make the most of that topic, tell us about your practice and what makes it unique. I could see there are Eye Surgeons of Indiana. Give us kind of an overview. It's definitely a practice that I think a lot of folks would love to be at.
So my practice, I've been here for almost 20 years now, and I actually got started doing a fellowship in retinal disease. So I worked side by side with our retina surgeon for a number of years and then have kind of branched out from there, perioperative care, glaucoma. It was probably about 10 years ago that I really got into the dry eye space and have become the leader for that in our practice. And now have maybe 50% of my time is dedicated to working with folks with ocular surface disease. But we're a large practice. We're primarily a referral practice, refractive cataract surgery. We're doing probably, 8,000 procedures a year. So a high volume cataract practice. We have about 400 optometrists in our referral network. I myself don't provide any sort of primary care services, refractive needs, contact lenses, etc. Those things get taken care of by our referral network. I definitely am in work, and dry eye has been a big part of that. So really our goal in our community is to identify patients and treat them with dry eye disease before they ever get to our practice. And then I'm here as a backstop in case doctors are, treating patients and they have some tough cases or some patients that just aren't responding to therapy. I'm here to support that. So again, I love that role, but I also love the possibility and the opportunity to be able to teach my colleagues how to do these things in their practices. And that's how we got to Eyes on Dry Eye.
Absolutely. So for those of you watching, please do ask questions in the chat. I've got it right here. We've had a bunch of questions coming in, which is great. So Damon, how did you determine that point-of-care diagnostics should play a role within your practice? I mean, that's an important decision to make, and I know you have your own kind of take on the why for that.
So I missed the very first part of the
internet.
Why. So help me understand what I'm looking for the why on.
No problem. How did you determine for point-of-care diagnostics to play a central role at your practice?
So I think that point of care, which I've used in my practice for the last 7 years, starting with tear osmolarity and then shortly thereafter MMP9, I think having actionable data points that give me objective measures to help me understand, does my patient have disease? How severe is that disease? How are they responding to my treatment? How might that point of care diagnostic maybe influence what I actually do to take care of the patient? So for me, there's 3 critical things that I'm doing on every patient coming in for a dry eye evaluation, or I've identified in my other clinics as having dry eye disease. Is they get a speed questionnaire check-in. We use the modified speed. They get a tear osmolarity test, and then they get InflammaDry MMP9. And they get that at every visit that they come and see me if we have a diagnosis of dry eye. They get that at their initial visit if they have signs or symptoms of dry eye, where I want to get a point-of-care diagnostic to help me make a better diagnosis and a better recommendation for my patient. Mm-hmm. And we also use that as an education piece for our patients. It's really nice to have an objective test that's yes, no, there's a red line if it's positive, it's not there if it's negative. I can show that to my patient. They understand that. It's kind of like a pregnancy test.
Yep.
They embrace that when I can say, hey, we've got a test that we can detect inflammation. It's going to help me understand what to do to treat your problem. I think the patient buy-in is important, but probably most importantly, why I have point-of-care diagnostic tests, it helps me make more confident decisions. It helps me be more efficient in clinic. It helps me have my patient ultimately have a better outcome.
Yeah, got it. I mean, just having the data is so critical from test to test as well. What about it? What about InflammaDry interested you initially, and what are you seeing now clinically with your patients?
So InflammaDry is going to be consistently elevated in patients with dry eye disease. It can be elevated in other disease states as well, but this is the proteolytic enzyme that causes damage to the ocular surface. So really it is the test for inflammation in dry eye. We've got other things that we can do that would infer inflammation, corneal and conjunctival staining. This is the only test that we can actually confirm that there's significant amounts of MMP9 on the ocular surface. Well, why is that important? In patients that have a high level of MMP9 or a positive InflammaDry test, those are patients that are going to typically require treatment with topical immunomodulators, lifitegrast, steroids. If they're InflammaDry negative, this is a patient that I'm going to probably, in some cases, treat in a different way. If they have a positive test, I know I'm going to have to be more aggressive with their therapy. If they have a negative test, I'm probably going to be able to back off on the anti-inflammatory that I recommend for that patient. So it's a trigger point. It helps me understand what's going on, their level of inflammation, and then I'm going to treat that accordingly, because we know that if someone is InflammaDry positive and I prescribe something like Restasis, they're much more likely to respond to that in a positive manner than someone that doesn't have significant amounts of inflammation that we can detect on the surface.
Yeah, having these tools at your disposal, especially the diagnostics, I mean, you're not going to waste the patient's time on certain treatments. It's just going to get better outcomes, better reviews. It's a whole cyclical system. It's very important. So describe to me kind of before something like InflammaDry, how did you go about treatments? Because this topic's very interesting. And how is it kind of altering the way you are treating patients, whether they are more or less using this as a diagnostic indicator, more or less inflammation?
So I think that if you don't have point-of-care diagnostics, there's a lot more guesswork involved. You're inferring a lot of things that you may not know to be true. I think you can still have an effective dry eye practice, a dry eye protocol. If you're doing a questionnaire, you're doing ocular surface staining, you're looking at the meibomian glands and looking at function. But I think adding that next layer was one of the first things that I did, even before I started investing in devices like Blefex and IPL and Ilex, TearCare, LipiFlow, all of those things. Before I did that, I got my protocol set, because I want to understand when my patient comes in, what's their baseline, what targeted treatments do I want to do for that patient, and are they responding to treatment? And I think having an objective measure with MMP9 levels with InflammaDry helps me to do that more efficiently.
Yeah, and I'm curious about just trends here. Is there a trend to do more testing with InflammaDry, and maybe are you seeing in the industry versus in your practice?
I think as a whole, it's still underutilized. I think optometry in particular, we really need to embrace looking for ocular vital signs. We need to embrace point-of-care diagnostics. Every other field in medicine is going to be using objective data to be able to make determination, does this patient have a disease or not? Is this something that potentially could be something that would spread? There's other tests that Quidel has. They've got over 80 tests in their arsenal. Not all of those are applicable to eye care, but do they have a disease? What's the likelihood that this is going to spread? Are they responding to treatment? And then can I target my treatment based on a objective measure, a biomarker, and not just simply guesswork or just relying on patient symptoms alone?
Yeah, so let's talk about asymptomatic patients. What's your workflow looking like with that?
So asymptomatic patients, everyone that comes in to see me for any sort of visit other than a post-operative cataract visit, they're going to get a questionnaire at check-in, a modified speed questionnaire. Regardless of what they're coming in for, they get that questionnaire. We have a protocol, a defined Eye Surgeons of Indiana standard of care for our dry eye patients that involves osmolarity and InflammaDry. If they come in and let's say they're coming in for a glaucoma evaluation and we determine that they have positive symptoms on that speed score, we're going to go ahead and get osmolarity and InflammaDry that day. Why would you do that in a glaucoma patient? Well, do I want to give this patient a topical prostaglandin and maybe make their ocular surface work? Or maybe do I want to do something like intracameral bimatoprost instead to be able to preserve that ocular surface? Maybe I want to move towards SLT instead of a drop. So I think that there's a lot of things in our patient base beyond just dry eye where it's applicable. And then certainly as a cataract refractive practice, we don't have that yet across all of our clinics as standard, but looking at the ASCRS algorithm, it really said the essential test to be able to determine if somebody has visually significant dry eye were both measurements of tear osmolarity and measurements of MMP9 levels.
Yeah, super, super like in-depth. I love that you're thinking about this as a protocol and being able to scale it across locations is a great way. And that none of this was available, just a couple years back. And so there's so much really, really cool stuff. I'm listening to so many, just whether it's diagnostics or treatments, new options for optometrists and ophthalmologists to take advantage of. So, when you're thinking about explaining this to a patient, how does that sound? And maybe the how it sounds to a patient will also be helpful for docs that are new to this and trying to understand how does InflammaDry work and what is it?
So I will admit that I will not be able to explain this to a patient very well because I don't do it that much. I have a staff member that does that. So these are tests that we have with a protocol that if someone has that check-in questionnaire and they have symptoms of ocular surface disease, that starts that protocol right there. And we're allowed to establish those sorts of standing orders with something like InflammaDry. So the technician will do some additional dry eye history questions. They will get an osmolarity, and then they'll say, we're going to go ahead and do a quick test to see if there's inflammation on the surface of the eye. And that's it. And then they get the test. It just takes a couple minutes to do. I get that test result before I ever walk into the room. So I have things with their symptoms and 2 different objective measures to have understanding of where this patient's at. It helps me make more effective decisions for that patient. It helps my clinic flow run faster when I have that upstream. So how we do the test, why we do the test, that's a technician role in my practice. I would just simply say, yeah, we did that inflammation test and that was positive. So we definitely need to have anti-inflammatories as part of your treatment plan. Patients understand that. They know what inflammation is. They know that inflammation is not a good thing.
Right.
And we have a yes/no test to be able to identify that. I think it's very, very easy to get patient buy-in with that.
Yeah, got it. And so, how long after instituting a few treatments, obviously there's a wide range of ways you might be treating a patient, but are patients kind of waiting and then finally you go, okay, the test came back negative and there's an aha moment, or not an aha moment, but a yes moment, and any stories like that?
So I think that a typical patient that has a moderate amount of inflammation and positive InflammaDry, maybe this is a patient that has some corneal staining as well, I would start them on a therapy with a topical steroid combined with an immunomodulator and see them back over time. If for some reason they are not getting better, I may have to change therapies. I'll look at their symptoms, their signs, as well as that MMP marker to be able to understand where I need to go from here. If the patient is compliant with their medication and I see that MMP9 is going from positive to negative, or maybe it was a deep red and now it's just very much a hint of red, I know that we're moving in the right direction. And in some cases, these point of care diagnostics will actually improve before the patient's symptoms improve. So this is such a teachable moment for our patients as, hey, I'm so glad that you're taking your Restasis. We're seeing that your inflammation test is better. Typically after I see that improving, your symptoms are going to improve as well. So I think we're on the right track. If we need to pivot to some other medication or a different treatment strategy, or maybe that goes from positive to negative, well, maybe I'm more inclined to put that patient's recommendation of punctal plugs. So there's just so much that test can do over time, both at the initial visit and at the follow-up visit. But if I'm treating the patient successfully, unless they have something like graft versus host disease or significant conjunctival chalasis, those patients are always going to be InflammaDry positive in my experience. If I'm treating a typical garden variety dry eye patient, over time, we are going to go from a positive result to a negative. And that's, again, an additional reinforcement for our patient. You're doing a great job taking your drops. Our therapies are working. If I do something like IPL, that can be helpful as well in improving MMP9. So there's so much value that a ocular biomarker brings to the table. Quite honestly, there's occasionally maybe 3 or 4 days I can think of in the last couple of years where we ran out of InflammaDry. it's harder for me to make the right decision for my patient without having that objective measurement.
Yeah, got to get you another case of that stuff. So, do you feel for maybe, I like what you said before, something about, I can't remember exactly, but either for a cataract or a glaucoma patient, how this is helping to change your treatment ever so slightly to just keep that patient get results faster and keep them more comfortable, especially at your practice, with heavy surgical. How is it, expand on that more if you don't mind.
So I think that we need to be able to meet our patients' expectations. At Eye Surgeons of Indiana, really everything that we do when we bring in technology, is this going to improve patient outcomes? Is it going to improve the patient experience? And I think InflammaDry for us checks both of those boxes. That's why we've been doing it since 2014. I think that if we fail to recognize maybe subtle or relatively asymptomatic ocular surface disease and then move forward towards surgery, this is a patient that can quickly be the unhappiest patient in your practice. I think if you're proactive at doing objective measurements of MMP9 levels, it's going to be one more thing to be able to bring to that evaluation and make a recommendation that we should maybe slow down our process and get your ocular surface treated before you have surgery. That way you have the best results. Patients have very high level of expectations. Cataract surgery, refractive surgery, this is a once in a lifetime opportunity for the patient. We have to embrace things that we have with these biomarkers to be able to provide better outcomes.
Yeah, and it's very important, I think, just from the optic standpoint, to have these tools in your tool chest from the patient's the visual of it all, their experience. It seems it is more sophisticated, and that reflects well as a practice builder.
Yeah, absolutely.
Yeah. So go ahead.
Go ahead, man.
Yeah. Anything else on that one?
No, I mean, I think that getting back to your question a few minutes ago, there's an opportunity here. This is something that optometry, quite honestly, hasn't embraced like they should. I even heard it in our sessions a little bit today. What's the value of doing this? Does this really change how we manage these patients? We know that there's studies that show if you have a positive InflammaDry, you're more likely to have a positive response to cyclosporin. We have a study that's in phase 4 looking at MMP9 and how elevated MMP9 levels eventually lead to loss of tear production. So these are things that if we don't embrace these things, our patients are not going to be able to get the recommendations that they deserve. I think there's going to be some need in the future to be able to justify for someone getting a prescription medication for dry eye that's a topical anti-inflammatory. You're probably going to need to have a diagnostic test to be able to back up your recommendation. So all of these things, again, we've said it a couple times here, we're leading to a better diagnosis, a more refined, targeted treatment approach. And I can't imagine doing what I do all day, every day in the dry eye space without having point of care diagnostics.
Yeah. Does Quidel have other point of care diagnostics or tests that have applicability or relevance in the eye care space?
So eye care space specifically, we do have the QuickView or Adeno Plus test from Quidel that helps us to detect if somebody has EKC. That is a patient that comes in with conjunctivitis. If they have a positive QuickView, I'm going to do a betadine wash for that patient, and they're probably going to need to limit their contacts with people for a while. If it's negative, that's great news because it means they don't have EKC or severe viral conjunctivitis. And I think that is going to be a data point that helps us make a better decision, a better diagnosis for our patient. And then most recently, Quidel is all over the therapeutic space, strep testing, big on COVID. We actually are one of the first practices in the country to be able to use their Sophia unit to be able to offer COVID-19 testing primarily to our staff at this point, but they have a nasal swab that we do. It's 15-minute test result, 99% accuracy.
Wow.
But if I hadn't already embraced, ocular vital signs as part of my everyday business, I would never have had the opportunity to bring something like that into my practice. And it's still evolving how we use that, but we got to start somewhere. There's going to be more tests in the future, but the time is now to do these things. Osmolarity, MMP9, some people would say mybography is a point of care diagnostic, but if we're looking at biomarkers, it's really right now tear osmolarity and then MMP9.
Yeah, lovely. Now, everyone out there who's watching, go to quidellihealth.com to learn more. That's QUIDEL ihealth.com to learn more. Definitely some really great information. It looks like there's been some excellent coverage of this with some cool journal articles and different blogs out there from folks. So likely a lot you can dig into on this topic. Damon, it's a pleasure. Anything else you want to close with? Actually, we're at the mark. I'm sure they're going to kick us off. But
yeah, I mean,
Dry Eye Game Show coming up.
Game show. Be ready. I think I'm ready. It's going to be fun. I don't know what's going to happen.
We'll see.
Tune in to find out. We've got about 40 minutes before the start of that. If you're in this session now, make sure you're checking in with the exhibitors. Again, this has been so much fun. Matt, your entire team, Ahmad on the clinical side. This has just been awesome, incredible. So happy to be a part of it.
Absolutely. I second that. I echo that big time. Everyone, enjoy the next session, and we'll see you later.